A very, a very good evening to everyone, and welcome to this great new webinar series. It's called the SFM Next Gen Expert Series, and you're going to wonder, where did that name come from? The name came from a brilliant idea that we had from Dr. Alok Vashni, and he was pointing out how so many of us who have grown in the wonderful fertile soil and been cultivated by the Society of Fetal Medicine do get a chance to blossom, but our blossoms are showing much more on other platforms and we're unable to exploit them. And so I told myself, well, this needs looking into. And when I spoke about this to Dr. Mohit Shah and to Dr. Bimal Sani, as well as to everybody on our executive committee, they agreed. They said, yes, we should get to see more of this new talent. And it's not just a question of new wine in new bottles, as they like to call it, or the fact that there is old wine in new bottles. It's a question of the best wine in great open-minded new bottles, because so many of us get so biased by what we hear and see as we grow up that we're not able to think out of the box or accept things in the open fashion that modern science demands. And so we decided, let's put together all of this, and we appreciate the talent of so many people who are now in the SFM family, and also get a chance to learn from them so that we get the best learning possibilities that we ever could. So thank you, Alok, for this brilliant idea, and thank you for putting this together. And over now to Dr. Mohit Shah for his welcome address.
Welcome, everyone. Welcome. And again, as Sir rightly said, SFM has been such pivotal in cultivating new, all brilliant minds into the topic of fetal medicine. We've seen that growth happening in the last 15 years, but more pronounced since post COVID, I believe, when the number of webinars increased, but more so when the younger people got attracted to it as a super specialty and now are in depth into fetal medicine. I thank Dr. Alok Vashni for his brilliant ideas that come up, and the fact that we are now exploiting these young minds to harness their intellect in a different way. The way they present, the way they have their images stored, the way they uh, keep a follow up, everything is so amazing. Even I learn a lot from them. They have such wonderful cases. Sometimes, we feel that we have such better cases, that we should actually come out with our own book. Maybe it be will be a pictorial essay. But the kind of cases that these young guns present are such marvelous cases. And we are really fortunate enough to be able to, get to see them. So I'm really looking forward to this webinar. Thank you so very much. Alok, let's get this rolling.
Thank you, Mohit sir, and thank you, Khurana sir, for conceiving and asking us to do this webinar series. And it is my pleasure to invite Dr. Seema first, because Murli seems to be having some technical difficulties in joining because heavy rains are lashing his part of India. So Seema, please share your screen.
Thank you, sir. Share my screen.
So Seema is a consultant radiologist. She is working in a small town of Gulbarga in Karnataka, and she works at a low resource setting, but she has excellent cases. And when I thought of this topic on fourth ventricular index, I had only one name in mind, that was Seema. She has completed her MBBS from MRMC Gulbarga, and she has been a regular contributor for WISWAG and ISWAG encyclopedias. And she also co-authored a book on fetal cardiac anomalies with me, which will be hitting the book stands very, very shortly. Thank you, Seema. You please go ahead.
Yes, sir. Thank you so much, sir. At the outset, I would like to thank Society of Fetal Medicine, Dr. Ashok Khurana sir, Mohit Shah sir, Alok Varshney sir, and Bimal Sahani sir for all the support and for the opportunity, of course. The topic which is given to me is fourth ventricular index. So when I was preparing for this topic, I had a few thought-provoking questions, like, do we look at the fourth ventricle at all in all our anomaly scans? No, because no guidelines have ever stressed upon it. Should we look at it routinely, and why? The answer is yes. Definitely, I'll be showing all the cases in which fourth ventricle was a clue for me to go ahead and do a neurosonography. And that's why we need to look at it routinely. We already know one more rectangular structure, which is a landmark, which helps us diagnose the abnormalities of the anterior complex in the axial plane. That is our cavum septi pellucidii. So we can say that the fourth ventricle is a new star in the fetal neurosonography. So as I said, we all are aware of how CSP is an important landmark in the fetal neurosonography, and it helps us diagnose anterior complex and midline anomalies. And how about the posterior fossa and the midbrain hindbrain region? So do we have any other savior here? So that important thing is the fourth ventricle. So let's see how these two rectangles, or how these two structures are oriented with respect to the axial plane. So I would want you all to bring your attention to the fact that the CSP, this rectangle, that is the CSP, is parallel to the midline, parallel to the axis in the axial plane, whereas the other quadrangular structure, or our fourth ventricle, is perpendicular to the axial plane. So this is the take home. So any abnormality in the orientation of these two rectangles should prompt us to go ahead and do a neurosonography, and abnormality of these two rectangles, either in shape or size, will definitely bring us to some amazing diagnosis. So the two heroes of our axial planes are CSP and the fourth ventricle. Now, why have we not been looking at this fourth ventricle? Because our visualization, or our box stops at looking at the cerebellum and cisterna magna, because our guidelines say so. So transcerebellar diameter and cisterna magna measurement has been included in the checklist. There is no mention about the fourth ventricle. So what we need to do is, we need to push the boundaries, and we need to definitely look at the fourth ventricle for its shape as well as the size. So as I said, today in this talk, we are going to focus. The main focus will be on the shape and the fourth ventricular index. The main character of this movie is fourth ventricle. So before we go to the fourth ventricular index proper, we need to know some of the features of the fourth ventricle. Now, fourth ventricle is an important structure. It is an important component of the ventricular system, in which the CSF, which is formed in the lateral ventricles, flows through the third ventricle via the foramen of Monro. This is the foramen of Monro. It goes into the third ventricle. Then via the cerebral aqueduct of Sylvius, it drains into the fourth ventricle. Then the CSF goes into the central canal and foramen of Lashka and Magendie. Through those two conduits, it enters into the subarachnoid space. So fourth ventricular anatomy is very, very important to understand. The anatomy in itself is a very big topic. And today we are going to restrict ourselves to the imaging part of fourth ventricle. So coming to the boundaries of the fourth ventricle, the floor is formed by the pons and the medulla anteriorly. The roof is formed by the superior medullary velum and inferior medullary velum. The point where the superior medullary velum and the inferior medullary velum and they communicate, or they join, is called the fastigial point. This is a very important thing which we usually see in the sagittal sections. So this is one important point which I want you all to remember. Then in the roof, we know that there is superior medullary velum and the inferior medullary velum. These two are thin sheet-like structures which cover the superior and the inferior cerebellar peduncles. We'll come to the cerebellar peduncles in the subsequent slides. In the coronal section, how does a fourth ventricle look like? It's a rhomboid shape. It's also called as a rhomboid fossa. Lateral borders are formed by the superior cerebellar peduncles, and inferior cerebellar peduncles form the inferior lateral border. And over that, covering superior medullary velum is present. So this is important because any of these structures, be it pons, medulla, superior cerebellar peduncle, cerebellum, vermis, any of these structures get involved, the shape of the fourth ventricle is going to be affected the same way as the corpus callosum. Being the CSP shape is mostly dependent upon the structure which is surrounding it. That's the corpus callosum. In the same way, all these structures are going to affect the shape of the fourth ventricle. So let's see how it is going to affect. So we all know, we all keep hearing what is cerebellar peduncle, cerebral peduncle. So today we'll be going, we'll be seeing what is the superior cerebellar peduncle and middle cerebellar peduncle and inferior cerebellar peduncle. So these are nothing but the fibers that connect the midbrain to the cerebellum. Of course, they get fibers from the cortex as well. So we'll just, for the sake of simplification, we'll just remember that these are the fibers that connect the midbrain and the cerebellum. Superior cerebellar peduncle. One which connects the pons and the cerebellum is a middle cerebellar peduncle, and one which connects the medulla and the cerebellum is a inferior cerebellar peduncle. So why are we talking so much about the superior cerebellar peduncle? We are mostly interested in the superior cerebellar peduncle because it forms the major boundary whenever we are imaging the fetal brain. So whenever we are imaging the fourth ventricle, we see that there are two lateral borders here. These are the superior cerebellar peduncles. It is important for us to know how the orientation of this superior cerebellar peduncle is in the normal fetus and in an abnormal fetus. We'll come to that. So what we are seeing in the sagittal section is that the superior cerebellar peduncle, it slopes downwards towards the cerebellum. It has a sloping, it slopes downwards, and that gives a characteristic appearance to the fourth ventricle, which is wider laterally and smaller anteroposteriorly. So anterior border is formed by the pons and the medulla, and posteriorly it is formed by the vermis. We'll come to that. Now, if at all I have to image the fourth ventricle, now what do I do? So we all know, we are all experts in getting the transcerebellar plane, because we do measure the transcerebellar diameter and we do measure the cisterna magna. So what we need to do is, we just need to go one level down, and then there is the fourth ventricle. This is the fourth ventricle, which we can see. We just need to one level down. Okay. So this is about how to image it. Now, how does it look normally? So getting acquainted to a normal structure, our brain recognizes the pattern as normal, and once there is any deviation from the normalcy, then our brain will quickly and our eyes will quickly pick up the abnormality. So we need to know how does it look like in a normal planes. So coming to the axial plane, it is a quadrangular structure. So wider sideways and smaller in the anteroposterior diameter. How does it look like in the mid-sagittal section? It looks like a triangular structure. This is the posterior border of the pons, and this is the fastigial point. So this is important. Coronal images. I tried acquiring coronal images for the talk, but the thing is, what I've observed is, in coronal images, the fourth ventricle is not easily seen because it is covered by the vermis in the front, and as we all know, the vermis will hide the fourth ventricle. It is not very easily seen. It might be seen if we go and take a image in the mid-axial and coronal section. So this is, we'll basically focus on the axial and the sagittal sections. So this is from the article. I have taken this image. So what we can understand from these images are, from 14 weeks to 36 weeks, in a normal fetus, we never expect the fourth ventricle to be like a CSP. It looks like it is wider always, okay, than taller. So it is always wider, be it 14 weeks, be it 28 weeks, or be it 36 weeks. It has to be wider sideways and smaller in the anteroposterior part. now that we know how a normal fourth ventricle looks like, just by eyeballing, we got to know that the fourth ventricle is normal. But for the sake of standardization, we need to have some parameter, like we have a CSP ratio there in the cavum septum. We have a ratio here as well, that is a fourth ventricular index. Now, what is the fourth ventricular index? Fourth ventricular index is lateral diameter. That is, we measure the widest part from side to side of the fourth ventricle. Then we divide it by the antero-posterior distance from the posterior aspect of the pons to the anterior aspect of the vermis. So what are the ratios? The normal fetuses, because the lateral diameter is bigger than the antero-posterior diameter, so always the ratio is going to be more than 1 in a normal fetus. Any abnormality affecting any of those anatomical landmarks will lead to the affection of this lateral and antero-posterior diameter, and that will lead to the fourth ventricular index going down below 1 center, less than 1 or below -2 standard deviations. So it should be like this. If it becomes like this, then it is abnormal. So whenever we come across the image having elongated fourth ventricle, even when we search it on the internet, the first thing which comes to our mind and also on the list is Joubert syndrome. So Joubert syndrome is the first diagnosis that comes to our mind. So what is a Joubert syndrome? Joubert syndrome is an autosomal recessive disorder. It's a type of ciliopathy with multi-system involvement. 30 genes have been identified to be causing Joubert syndrome. And the classical systems which are the basic systems which are affected are the brain, the kidney, and the skeletal system, with the molar tooth sign being the classical in the brain, echogenic and cystic kidneys, and polydactyly in the skeletal system. So let's go to our case and have a look. This is a axial sweep of the brain in the transcerebellar region. And what are we seeing? We are seeing that the first thing which catches my eye is the open fourth ventricle. So whenever there is an open fourth ventricle, it is easy. Then we go and do a detailed neurosonography. So again, what are we seeing here is we're also seeing that there is a thickening of the superior cerebellar peduncles. There is a narrowing of the lateral diameter and increase in the antero-posterior diameter, which gets us to the fourth ventricular index less than 1. And this appearance of the brainstem and the fourth ventricle together forms the molar tooth sign. So which is a classical for Joubert syndrome. So we all should know why this appearance of molar tooth sign we get in Joubert syndrome. It's because the gene basically affects the midbrain and hindbrain region, where the isthmic region goes into hypoplasia, the vermis goes into hypoplasia. The only thing which goes into hypertrophy or thickening is our superior cerebellar peduncle. There are 3 components. The one is the midbrain, superior cerebellar peduncle, and the vermis and the posterior pontine pons. So what happens? There is a deepening of the interpeduncular fossa due to a thin midbrain, and there is thickening of the superior cerebellar peduncles, which forms the root of the molar tooth, and that causes reduced lateral diameter, and the anterior border goes into hypoplasia, that is the pons, and the vermis, which is a posterior border, also goes into hypoplasia. That increases the anterior posterior diameter, giving it a typical appearance of molar tooth sign. So we are all used to this appearance looking into the axial planes. So this is a deepened interpeduncular fossa. These are the thickened superior cerebellar peduncles. This is a classical appearance of the fourth ventricle, which is elongated, and this gives a molar tooth sign. This is the normal appearance of the superior cerebellar peduncles. This is the posterior surface of the pons, and this is the midbrain, which does not have any deepening here. This is a normal thing. So let's now train our eyes to see this in the sagittal plane. So I've used the MRI images so that it is easy for us to understand. So this is the MRI image. This is the superior cerebellar peduncle. The orientation is downwards, sloping downwards from the posterior border of the brainstem. Now, what is happening in the Joubert syndrome is the superior cerebellar peduncle becomes thickened, it becomes malrotated, and it is at a perpendicular angle from the posterior aspect of the brainstem to the cerebellum. So the same thing is seen in the coronal plane. We can see that there is thickening of the superior cerebellar peduncles. Now, shall we translate it into our prenatal case? So here we are seeing the sagittal section of the same patient where we saw the axial planes, 21 weeker. So what are we seeing? The very striking thing which should catch our eye is again a fourth ventricle. Here the fourth ventricle is not triangular and it is rounded. So it is rounded. Yeah. And this is our superior cerebellar peduncle, which is bang 90 degree to the brainstem. So this is how it appears. So next important thing is we do not have any vermis in this. Echogenic thing is just riding high is the vermis. So what is this? This is a cerebellar hemisphere. This is the cerebellar hemisphere and not the vermis. So this image, we have to compare it with the MRI image. And this is how the superior cerebellar peduncles are oriented in the MRI. It's same as in this case. So we'll go to the next important thing is the study of the cerebellar hemisphere and the vermis. From the schematic diagram in this, in a case of Joubert syndrome, what happens is there is the thinning of the isthmus. So the abnormality affects the isthmus. Isthmus is the junction between the midbrain and the pons, and there is thinning of this because there is Vermian hypoplasia. It is a high riding, the vermis is high riding, and whatever the portion, remnant portion is seen is a contralateral cerebellar hemisphere and not the vermis. So this is the hemisphere which is seen here. So now what is important in this is the vermis usually, whenever it is normal, it will be when we draw imaginary line through the isthmus, that is at the junction of the midbrain and the pons, that line cuts the vermis into upper 1/3 and lower 2/3. So here we can see the clear difference that vermis is high riding and the cerebellar hemisphere on the other side is visible and not the vermis. We should never mistake it for vermis. So coming to the coronal plane, as I said, we will not be able to see the fourth ventricle very nicely in our normal coronal planes because it is covered by the vermis. So this simply tells us that the vermis in Joubert syndrome is hypoplastic and we are able to see the fourth ventricle very, very clearly. So these are the cerebellar peduncles and this is the fourth ventricle. Coming to the next case, this is the axial sweep of 20. This is a 20 weeker. The axial sweeps show that there is nice CSP, there is no ventriculomegaly, and the cerebellar hemispheres are okay. They don't look small, and the only thing we have to focus in this case, if I didn't focus on the fourth ventricle, then maybe we would have definitely missed this case because there is no other clue. If I follow the guidelines and not look at the fourth ventricle, neither the fourth ventricle is open and it is communicating with the cisterna magna. So this was the first clue in this case, and we went ahead and did a sagittal. We did transvaginal neurosonography, and we did take sagittal sections where we again could see that the fourth ventricle was had lost its triangular appearance and it had become more rounded, and we could hardly see any vermis here, and we could see that the cerebellar peduncles were there. The perpendicular orientation of the cerebellar peduncle, superior cerebellar peduncle was there, and that was an abnormal fourth ventricle. So does it bring us to our equation that fourth ventricular index less than 1, elongated fourth ventricle is Joubert's, and can we all be happy with this and move on? Are all elongated fourth ventricle Joubert syndrome? Are we going to put a label that everything which looks like the elongated fourth ventricle is there, and we end up saying that it is a Joubert syndrome. No, it is not so. So these are some research papers which have stressed upon the fact that looking at the fourth ventricular index is a sonographic marker for Vermeer dysgenesis, especially when the fourth ventricle is not communicating with the cisterna magna. When the fourth ventricle is communicating with the cisterna magna, definitely we go and do all our planes. But in some cases of severe Vermeer dysgenesis and eugenesis where it is not communicating, the only clue will be fourth ventricle. So this is a paper stressing upon the fact that fourth ventricle does help as a screening tool and pushes us to look for the brainstem anomalies. And now that we have seen that the our fourth ventricle should be a rectangle which is perpendicular to the axial plane. Now let's see how that got changed to a rectangle. It becomes a look-alike CSP. How does it happen? Because whenever there is abnormality of the superior cerebellar peduncle or the cerebellum, which form the lateral borders, so what is going to happen is they are going to compress the fourth ventricle. The lateral diameter is going to decrease. When the numerator decreases, obviously the fourth ventricular index is going to fall. So what are the conditions where we are going to look at this is Joubert syndrome related disorders, then cerebellar hypoplasia and rhombencephalosynapses. So what are the conditions where the anteroposterior diameter is going to increase? So it happens because of the anterior landmark, that is a pons. Whenever the pons undergoes hypoplasia, it increases, and whenever the vermis undergoes hypoplasia, it is going to increase. So this is what we got to know. So once we have a fourth ventricular index less than 1, we are going to look at vermis, fastigium, superior cerebellar peduncle. If we get a molar tooth sign, then it is GSRD. If cerebellar hemispheres are abnormal, they have lost the shape, and the transcerebellar diameter is less than 5th centile, then it is a rhombencephalosynapsis. Careful examination of the brainstem can help, because once there is a Z-shaped kinking of the brainstem, along with that, if we see an echogenic cortex, then we are dealing with cobblestone malformation. And cerebellar hemispheres and the pons, if they are very, very small in size, then we are dealing with pontocerebellar hypoplasias. I'll be showing few cases as well. So once the fourth ventricular index, how do we approach? Look at the transcerebellar diameter. I'll just, transcerebellar diameter, if it is normal, then if it is showing a molar tooth sign, then it is a Joubert's. If it is less than 5th percentile, then with the loss of the dumbbell shape and the normal shape of the cerebellum, then it is rhombencephalosynapsis. If it is maintained and only the TCD is less than 5th percentile, then it is cerebellar hypoplasia. Brainstem has to be looked for kinking, as I said, Z-shaped brainstem, for cobblestone malformation, as in Walker-Walker. We'll quickly go through all our cases. This is a 20-weeker. What catches my eye is an open fourth ventricle here. Sorry. Sagittal sections. In sagittal sections, what are we seeing? So as we saw, as we know, there is an open fourth ventricle. We need to focus on the mid-sagittal and the parasagittal sections. In the sagittal sections, what are we seeing? Does the brainstem look straight? No, it has acquired a Z-shaped appearance. So I'll just bring out the images, stop the videos. So what are we seeing? We are seeing an open fourth ventricle, and on examination of brainstem, what are we seeing is a Z-shaped brainstem. So, and then we went ahead and did a coronal sweep of the same in order to see whether the vermis is present or no. And what we could see is the vermis is hypoplastic. It's not complete. There is a little bit of vermis which is seen, and anyway, it is dysmorphic. So then most important thing, as I said, we need to go ahead and look at the cortical surface. Does the cortical surface look smooth? Does it look normal? Of course, this is a 20-weeker, I said, but at this point of time, the cortex should not look so echogenic. Never during any gestation, the cortex looks so echogenic. So this brings us to a conclusion. So what are we seeing is, we are seeing the echogenic cortical surface. So this is an echogenic cortical surface. This is a image showing, titulated image showing how cobblestone lissencephaly looks like, because of over migration of the neuronal cells beyond the level of the cortical surface, and they go and settle on the pile matter and the. So this is how it looks like in the histopathology. We should not see the glial cells, neurons beyond this level. And this is how a normal brain looks like. So in this case, we also had microphthalmia, and there was some echogenicity in both the orbital cavities. So coming to the diagnosis here was Walker-Warburg. It is autosomal recessive disorder, dystroglycanopathy. It involves the eye and the brain. It also involves the muscular, also has a muscular component where there is severe contractures of the upper and lower limbs. So Z-shaped brainstem is important. Coming to the next case, here is a 32-weeker. We'll just focus on the fourth ventricle. Here the fourth ventricle looked abnormal. I'll just play the video. It was elongated. On measuring the transcerebellar diameter for a 32-weeker, it was only 20 millimeters, which corresponded to 19 weeks 5 days, which is less than 4 centile. And on the sagittal planes, what are we seeing? We are seeing that the pons and the midbrain pons and the medulla, the brainstem as a whole, along with the supratentorial cortical region, everything appears atrophic. So we'll just focus on the brainstem. Okay, so this is the pons and it's thinned out. So everything is so thin. Midbrain is hypoplastic, the pons is hypoplastic, and the medulla is also hypoplastic, giving it a. So this is not mentioned. Progressive supranuclear palsy has a hummingbird appearance in adults, but I failed to get it for fetal. So if we focus on this region, this is a normal case, this is an abnormal case. This is how it is in this case, 32-weeker. This is a 31-weeker, and this is how the pontine belly is bulky. This is how it looks like. So this is the midbrain, and this is the pons, and this is the medulla. So it has got shrunken. So to show it, this is the pons, this is the midbrain, pons, and medulla in our case, and this is the midbrain, thick midbrain, normal pons, and normal medulla. So there are calculations for everything. Due to lack of time, we're skipping that. In the same case, we could see that there was a very simplified gyral pattern gyration in this case. We also had subependymal, we also had ganglionic eminences, which we thought was the etiology for all the findings. So there is a cortical atrophy, transfrontal, and this is at the level of transthalamic plane. So coming to the next case, this is a case 21-weeker. By just eyeballing, we could make out that the cerebellum was a little smaller. Focus on the fourth ventricle. That shows us that even here the fourth ventricle is elongated, and TCD was less than, it was on first centile. So it is a 20-weeker, but the TCD is corresponding to 17 weeks 3 days. On sagittal sections, this is not as obvious as it is in the previous case. It is very subtle that there is no pontine belly here. So the pontine belly is very, very flat. Everything is hypoplastic, and we need to focus on the brainstem whenever we have a elongated fourth ventricle or fourth ventricular index less than. So this is a comparison again. So this fetus also had multiple joint contractures. Pontocerebellar hypoplasias are heterogeneous group of disorders, autosomal recessive, abnormal small cerebellum and brainstem are seen. They are. Why are these important? Why should we go ahead and pick them up, catch them early? Is they cause profound intellectual disability and cause psychomotor delaying of the milestones. And there are 16 types of pontocerebellar hypoplasia, and multiple genes are involved. This is my last case. So this is a 26-weeker. What are we seeing is there is bilateral, all the three ventricles are dilated, third ventricle and lateral ventricles are also dilated. If we focus and see, then there is a slit-like fourth ventricle, one which is here, And if we focus on the shape of the cerebellum, there is a loss of dumbbell shape, and this is looking, and there is continuity of the folia across the cerebellar hemisphere. There is no vermis. And this gets to diagnosis of Roman capillosynapsis, fused cerebellum. And so this is how we saw all our cases. So this is these two were Joubert's, this is Roman capillosynapsis, this is cerebellar hypoplasia, and this was pontocerebellar hypoplasia with simplified gyral pattern in the supratentorial region. So these are the sagittal images of the same. For the sake of time, we'll just skip that. And what was the important thing which was common for all was Vermian hypoplasia. So Vermian hypoplasia, whenever the vermis is hypoplastic, definitely the fourth ventricle shape will be abnormal. If we are very careful enough to do a proper neurosonography, we will definitely pick this up on imaging. So take home messages from the talk: look for the fourth ventricular shape size. CSP like fourth ventricle is a red flag. Do a detailed neurosonography. Look for vermis, pons, midbrains, superior cerebellar peduncles, and increased fourth ventricular index is there in Joubert's, pontocerebellar hypoplasia, Roman capillosynapsis, cobblestone malformation, and molar tooth sign in Joubert's is not unique for Joubert's. It also is seen in Coates and Malta syndrome, etc. Thank you so much for the patient listening. These were my references. Thank you so much. Thank you so much for the opportunity.
Thank you, Dr. Seema, for your excellent presentation. And you covered fourth ventricle index, the shape, in such a great detail. I think everybody will understand that fourth ventricle elongation is not only about Joubert syndrome, but other abnormalities can also be there. Thank you for enhancing the knowledge of everyone. Great presentation. And the cases, as Khurana sir will say, simply delicious. Okay, today the next speaker is Dr. Murlidhar Kamlapur. He is an assistant professor at Father Muller Hospital in Mangalore, and he was facing some technical difficulties, but I hope he's sorted them out now. So, Dr. Murli, can you please share your screen? Yes, make it full screen.
Yeah.
And he'll be presenting another, a niche topic, that is the importance of fourth ventricular choroid plexus. And I know he's going to do a great job. Over to you, Murli. Thank you.
Yeah, thank you. So good evening. At the outset, I would like to thank SFM, Khurana sir, Alok sir for this opportunity and starting this new segment. This will be a big game changer in taking this fetal medicine to the next level. So my talk is given was the choroid plexus of the fourth ventricle. Then as I went on reading, I came to know that there is something called a flower. So in the brain. So what is the flower in the brain? That's nothing but the choroid plexus of the fourth ventricle. So going back a little bit about the developmental anatomy, it's usually at the seventh gestational week, the plica choroidea represents the first evidence of the fourth ventricle choroid plexus, and this becomes evident at around 18 to 20 mm of CRL. Later, as we progress to 12 to 13 weeks, that is when we get to do the NT scan, the Blake's pouch becomes fenestrated to form the foramen of Magendie. At 26 weeks, the lateral foramen of Luschka becomes evident according to the most supported theory. And this is what is a normal course. So let's go back and see that. The fourth ventricle, it's basically a tent-shaped midline cavity located between the cerebellum and the midbrain. So it has a tent in shape. So this is a case of Dandy Walker. That is how I could render this fourth ventricle, not only in sagittal but also in coronal. So what you see is the sagittal section. You can clearly appreciate on this diagram, there are various divisions. This we are very familiar, the anterior membranous area, the choroid plexus, the posterior membranous area, etc. And what I want you all to understand is the coronal section, which is a tent shaped. The apex of the tent is what you corresponds to the anterior membranous area. And in the middle, you have the foramen of Magendie. On either ends, the ecogenic part on one side, what you see is the choroid plexus, and down where you go, you see is the posterior membranous area. The rendered image clearly shows the brainstem and the two lateral choroid plexuses sitting at the lateral angle, and the tent is where you find the anterior membranous area. Right on the opposite end, you find the posterior membranous area. So when I was rendering, I could find some similarity between with the map of India, right? So that is how the fourth ventricle looks like on a coronal section. So embryological basis, as I already told, it's the rudimentary fourth ventricle choroid plexus, which appears at 44th post-ovulatory days. You need to know certain areas. The anterior membranous area is the velum above the this is the fourth ventricle choroid plexus. This is the vermis. Just cranial to the vermis you find is the cerebral aqueduct. Just above the choroid plexus, you find the anterior membranous area. Just below that, you find the posterior membranous area, and down is your cisterna magna. Anterior to that, you have the pons and the midbrain. So anterior membranous area is that part which lies cranial to the fourth ventricle choroid plexus, just underneath the cerebellar vermis. And this is the region where you usually find the dandy walkers coming out. Just below the fourth ventricle choroid plexus, you find is the posterior membranous area. That is where you get the Blake's pouch, and the down continues into the cisterna magna. So what I'm going to talk about dandy walker and Blake's pouch gets derivative from the anterior and the posterior membranous area. So what is the flower basket? It's nothing but the two terminal parts of the lateral segment of the fourth ventricle, which further protrude through to the foramen of Luschka. These were given the name as Bochdaleck's flower basket. In German, it's called as Blumkorpen. So why this name? It resembles an array of flowers in the flower basket. This was again named after the Bohemian anatomist Vincent Alexander Bochdalek, who described this particular region of the fourth ventricle choroid plexus, in addition to the normal and abnormal appearance of its anatomical structures. So it's a T-shaped structures. It has an oval shape with double vertical limbs. It has two horizontal limbs and two vertical limbs, right? The two inverted L-shaped structures, what you see, form the horizontal limbs, and these two limbs form what is known as the Bochdalek arrangement of flowers. And it is these two horizontal limbs, which pave the way to formation of another sign, which I'll be discussing later, right? So basically it is a T-shaped structures. It has a horizontal limb as well as the vertical limb. The two terminal parts of these go through foramen of Luschka and form the Bochdalek's flower baskets. Optimal timing, lot of research has been done. It's say the 12 to 14 weeks is the best time to look for these plexuses. Normally, best done using a 6 to 12 megahertz transvaginal probe using the standard guidelines. And as I go through the presentation, you'll understand why it is so important to have a multiplanar imaging. So evaluation of the choroid plexus of the fourth ventricle is not complete without your multiplanar imaging. So this is the one which we are all well versed with, which we all do on a regular day-to-day practice. So a sagittal section we take while look for the NT. You basically look for the brainstem, the posterior end of the brainstem, the future fourth ventricular IT, and this echogenic part is what is the choroid plexus of the fourth ventricle. This is what we are very much familiar. Posterior to that is the cisterna magna and the occiput and the NT. So this image we are very familiar with, right? So we'll go ahead and see the same choroid plexus in a different view. So what happens? These are all volume rendered images. So It's always that we evaluate the fourth ventricle choroid plexus through volume rendering. As I told earlier, it has an horizontal as well as the vertical components. In this 14-weeker, you can appreciate two horizontal component and two vertical components going down. The same thing is seen more pronounced in case of 16 weeks. And then in 22 weeks, you are able to see the Bochdalex flower baskets at the end, right? So this is the appearance of the fourth ventricle choroid plexus on a coronal section at 14 weeks, 16 weeks, and 22 weeks. So what you look for is the horizontal limb as well as the vertical limb. So multiplanar imaging is here. It is the imaging modality to evaluate the choroid plexus of fourth ventricle. You basically go with the mid-sagittal plane where it shows downward and oblique course. Is what you look for is the longitudinal limb of the fourth ventricular choroid plexus. They lie caudal to the vermis and cranial to the Blake's pouch. When you look and render it on a coronal plane, you see that this is a case of a dandy walker. So to make it more visible, you see the choroid plexuses down here. The coronal section shows a cyst, right? And the choroid plexus sitting down. And the same thing, I put my cursor here and I can appreciate the choroid plexus in the axial section. So the point of this slide is you need to go with a multiplanar imaging of seeing the choroid plexus. This was rendered at around 13 weeks. So that is when you're going to appreciate the vermis, the cyst, and the choroid plexus in relationship to the cyst. Something which we are all familiar. Recently, this is one of the signs which came up, known as choroid bar. This is a visually continuous, homogeneously hyperechoic thick structures in bridging the cisterna magna from side to side. It is nothing but the horizontal limbs of the fourth ventricle choroid plexus approximating each other, and that is what they form the choroid bar. Presence of a normal choroid bar indicates a normal posterior fossa development. So there are multiple approaches. It can be approached through dorsal ventral insunation at 13 weeks. Multiplanar imaging shows how a posterior fossa changes with different acquisition planes. And a normal appearance is a CSF fluid which is present both ventral and dorsal to the choroid bar. This is an axial section. Clearly observe as I go to the posterior fossa, I'm nicely seeing a choroid bar, which is nothing but approximation of the two horizontal limbs of the choroid plexus into the middle, right? They approximate and form the choroid bar. And what we see fluid, both ventral as well as dorsal to the choroid bar. So when you see a thick hyperechoic structure approximating in the middle with fluid, both ventral and dorsal, that's a normal choroid bar, rules out a good number of posterior fossa anomalies. So what were the novel findings of this study? It could be seen regardless of the line of insunation, which makes accessible, which very accessible for routine screening. And it's not visible in Chiari malformations, nor in Vermean malformations or Dandy Walker or Blake's pouch. And early detection, it can be done and imaged at around 12 to 14 weeks. So the key advantages were easy visualization. It proved to be a consistent marker, which was present in normal and absent in abnormal cases. A dual detection, it raises suspicion of both spinal dysraphisms. Let's not forget uh, spina bifida. That's not in this discussion of posterior fossa cysts. That can also be diagnosed or suspected because of absence of this normal choroid bar, and it is early evaluated at 12 to 14 weeks. Of course, no study is without limitations. It included only Dandy Walker, BPC, and Chiari-2 malformations. It was a retrospective analysis. Only abnormal cases were evaluated and it on stored databases, and different techniques like the prospective cases mostly used 2D transabdominal, while retrospective had a 3D transvaginal. So it had its own limitations, but yes, this is a new thing which has come up, which we all look for in our day-to-day practice. Appearance, at around 12 weeks, it appears as an echogenic tip just below the vermis, right? At some point of time, you see there is some gap between the vermis and that of the echogenic tip, that is the choroid plexus. That's because of the presence of the anterior membranous area. This is also a more apparent and less apparent as the gestation goes on. And at around 20, 21 weeks, we are seeing that the section of the choroid plexus is reduced as compared to the vermis, but that gap between the vermis and the choroid plexus has now disappeared. This was a case of black spot cyst. But as the pregnancy progressed, you can clearly see a nicely developed vermis, and the choroid plexus is now hardly visible. So as the pregnancy advances around 21 weeks or even at 30 weeks, it becomes very difficult to visualize because of its decreased size, right? That the vermis goes on increasing, the choroid plexus goes on reducing in size, and this vermis goes on approximating with the brainstem, and it's very hard to look for the fourth ventricle choroid plexus. So increasing difficulty, it becomes progressively more challenging to demonstrate in advanced pregnancies. You have to follow other advanced techniques, high resolution imaging, proper positioning, etc. You need to go and through the anatomical barriers. The CP angle fissure is hidden by several anatomical structures, including the skull base, and awareness is the key. Like, you need to be aware of its position and how to image. Technical consideration is very important while imaging the choroid plexus. It's always best to go with the highest. Use the high resolution probes. I usually go with the TVS, and these days I am also using the RM7C transducer, which gives good resolution, provided the fetal position is good, and uh, even the fetal head is good, is not an obese patient. Use high resolution probes. It significantly improves the detection. 3D ultrasound is very important. And most importantly is have a posterior fontanelle approach, right? And assessment may not be done in all cases, as only in those cases where you suspect some anomalies. This was a study which showed the diagnostic accuracy of visualizing the choroid plexus, as well as looking accurately the position of the choroid plexus. It was well seen at around 12 to 13 and 20 to 21 weeks. Even the position was well made out at around 12 to 13 weeks rather than 20 to 21 weeks, right? So again, we go back to that stage where say 12 to 13 weeks is, maybe I would put it as 13 weeks, not 12 weeks, at the best time to look for the choroid plexus of the fourth ventricle. Now, coming to the diagnosis and it's the role of this choroid plexus, it entered the diagnostic arena after the description by Donetti et al. In 96 of the Blake's pouch as a pathological entity, distinct from megacisterna magna, right? There were fetal demonstrations done for the BPC, Vermian hypoplasia, Dandy Walker, etc. But as we all know, there are certain limitations of the Vermian biometry. We all know that the Vermian biometry, what charts we have, they have incorporated the fourth ventricle choroid plexus and taken the craniocaudal measurement. So now a lot of these recent papers by Volpe et al. In 2021, 2023 say that, yeah, we need to have separate charts where we have excluded the fourth ventricle choroid plexus. And most importantly, what has come out recently is looking for the position of the choroid plexus in diagnosing posterior fossa anomalies. I still remember 7, 8 years back when we were listening to talks on posterior fossa malformations in first trimester. We were told that you just mention it's a posterior fossa and never comment whether it's a Dandy Walker or Blake's pouch. Well, now in 2025, through various research and improved in ultrasound transducer technology and the anatomy, a better understanding of the anatomy, we can to a greater extent, to much accuracy, set them apart, right? Clinical implications, early differential diagnosis, improved prognostic information, and enhanced prenatal care. So the two entities, the Blake's pouch, which arises from the posterior membranous area, which lies just below the choroid plexus, right? This is a normal phenomenon. where the mejendy fenestrates and it resolves. And the dandy walker, which comes from the anterior membranous area just below the vermis and pushing the choroid plexus down. Now, coming to some cases, in the first trimester, this patient came for a routine NT scan. Looks fairly okay, but the posterior fossa shows a different story. The brainstem to occiput ratio was more than the 95th centile. And then when we took a cranial sweep, we could see that, yes, I am able to see the choroid bar, but they are separating. And what I am seeing here is the rounding of the cisterna magna. So this drew me suspicion that, yes, this is not, of course, this is a variant. This could be a Blake's pouch. Then what happened? We just did direct coronal sweep. Direct coronal sweep showed that there was a cyst where the choroid plexus was sitting right on top of the cyst. This is a section which showed choroid plexus sitting right on top. The volume rendering showed there is mild rotation of the vermis fastigium was seen, and the axial section clearly showed the hourglass configuration, which is very classical to Blake's pouch. But what I want you all to understand is to appreciate that the choroid plexus is sitting right on top over the cyst. Right, the choroid plexus sitting right on top over the cyst. Now, this was another case. This was at 14 weeks. This was on a trans volume. I mean, trans abdominal RM7C. What I have done here. You can appreciate the dot is put on one limb of the choroid plexus, the lateral limb. So I am more lateral here on the sagittal section and on the axial section. So this is the two choroid plexus, and when these approximate, they form the choroid bar, right? So when I have put my dot on the lateral aspect, I am seeing the choroid plexus on the lateral aspect, and I am seeing on one end of the horizontal limb. So this is a normal horizontal limb of the choroid plexus, and down you have the vertical limbs. This was another case of a Blake's pouch. Now, in first trimester, if this progresses further, what happens? This was a case which came up, which showed posterior fossa cyst, right? You're seeing a posterior fossa cyst, but you're not seeing the choroid bar. So that is a high index of suspicion that you're not seeing the choroid bar. This is enough to make you suspect that I am having something abnormal in the posterior fossa. And on the sagittal section, I am seeing a big brainstem to occiput ratio, which is usually more than 95th centile in such cases. Most importantly, you don't see the choroid plexus in a dandy walker on a sagittal section because they're pushed down and lateral. You need to go lateral to look for the choroid plexus, unlike Blake's pouch, where you are able to see some portion in the sagittal section. And upon volume rendering, here I could appreciate the elevated or the rotated vermis, and purposely I put the dot here, right? I can appreciate that you can also appreciate the dot on the coronal section. You are able to see the choroid plexus, which is pushed down and out, and you are also able to see the pushed out in the axial section. So what I am not seeing here is the choroid plexus in the sagittal section, but I am able to appreciate them in the coronal section. I'm able to see partly here. That's because they are pushed down and out. So what happens when I put my cursor onto the choroid plexus on the side, on this section, I'm able to come to the lateral aspect and appreciate the choroid plexus down here. So it's very important to know the position of choroid plexus with respect to the cyst. So that gives the clue to tell what type of cyst are you dealing with, right? On further imaging, I went further lateral and I could appreciate the choroid plexus nicely, and then put my cursor here at this region on the coronal section with respect to the choroid plexus here. Volume rendering was done in HD live and transparency mode. You can appreciate the posterior fossa cyst with elevated vermis and the choroid plexus sitting down, right? This transparency mode you can also appreciate the margins or the wall of the cyst. So what we saw was in a Blake's pouch, the choroid plexus was sitting up cranial to the cyst, whereas in Dandy Walker, they were sitting down and out. Another case you can appreciate, there is a nice, there's a big posterior fossa cyst. This was a very obese patient, but on further evaluation, there was a posterior fossa cyst seen. There was thinning of the brainstem. This was the only position I got while doing the transvaginal scan. So this was a posterior fossa elevating the uh, vermis, and you are seeing the choroid plexus down here, right? On this section, you are seeing the choroid plexus sitting down, and this is a huge posterior fossa cyst. On volume rendering, I could, at the same tent, what I showed in the earlier section, you can appreciate the anterior membranous area, posterior membranous area, and this is the choroid plexus. And this on sagittal section, you can appreciate the huge cystic lesion in the anterior membranous area, elevating the vermis, pushing the choroid plexus down. On volume rendered image, you can see the huge posterior fossa cyst. Of course, this also had a separated nuchal edema. This was a case of trisomy 21 on invasive testing. And this choroid plexus was rendered and it was seen pushed down and out. So various cases have been shown to just to reaffirm the finding that choroid plexus is a good marker, a reliable marker to predict whether it's a Blake's pouch or a Dandy Walker. Another case, we could appreciate a posterior fossa cyst pushing the vermis, the choroid plexus down. I'm nicely put the dot here on the choroid plexus on the coronal section, corresponding dot on the sagittal and the axial section. A volume rendered image clearly shows the choroid plexus sitting down. This is your brainstem, and here is your elevated vermis. Coming to two cases in second trimester, this patient came to us and for an anomaly scan at around 20 weeks. This is what we saw.
Sorry, Murli, please, can you hasten it up because you are running out of time?
Yeah, I'll hasten it. This was a case which came up at 21 weeks. We could see an hourglass configuration. This is what we saw initially, but on further evaluation, we could appreciate that there was a posterior fossa cyst with ventricle choroid plexus sitting up. On further evaluation, multiple reconstruction, we could appreciate that there was mild rotation of the vermis with mild echogenic choroid plexus, and this was rendering done. Where based on these findings, we gave a diagnosis of Blake's pouch, and this patient came to us, and from 22 weeks to 34 weeks, we could appreciate vermis growing nicely, choroid plexus reduced in size, and this turned to be a totally normal case. Another case of Dandy Walker in second trimester, you can appreciate widely spaced vermis, and then on the coronal images, and then on sagittal, you can appreciate vermin hypoplasia due to a huge posterior fossa cyst. On rendering, we could appreciate the posterior, huge cyst pushing the choroid plexus down. Most importantly, you can appreciate I'm in mid-sagittal section. I'm unable to see the choroid plexus, but when I go lateral, I'm able to see the choroid plexus. This is again to emphasize the position of the choroid plexus. The key diagnostic feature in cases of Dandy Walker, it's always down and out. In case of Blake's pouch, it is up and lateral. Clinical recommendation, best is to 12 to 13 weeks. Second trimester is to follow up. Key tools are good transvaginal and volume imaging. So Dandy Walker malformation on mid-sagittal view, you don't get to see the fourth ventricle. It is displaced down and out, so go parasagittal. Coronal section helps a lot, especially in 12 to 13 weeks. Visualization rates of around 87% in 15 to 16 weeks. Position related to the cyst, it's always down and out when it's case of Dandy Walker. In Blake's pouch, here the position of the choroid plexus always up and lateral. That's visualization is very good. They say it's after 100% in 12 to 13 weeks and 96% in 15 to 16 weeks. So the most important is the position where it goes up and out. So how do you differentiate? You differentiate them with displacement of the choroid plexus. And in open spina bifida, they are pushed laterally. So what happens in neural tube defect? You can appreciate that the choroid plexus is compressed between the occipital bone and the midbrain, and it is pushed laterally. The pathogenesis is, we all know, there is juxtaposition of the fourth ventricle choroid plexus. So normal anatomy is what you look for: the choroid bar, fluid anterior and posterior to it. GR2 malformation, everything goes off. You, everything gets obliterated. But here in cystic malformation, you're seeing a posterior fossa cyst with absent choroid bar. How does your clinical workflow goes up? First trimester screening, you identify to suspect posterior fossa anomalies based on abnormal hindbrain spaces, detailed evaluation for fourth ventricular choroid plexus position, and you differentiate and classify them based on the position into Dandy Walker or Blake's pouch. So this workflow helps us to uh, pick up and tell. And another point, in Blake's pouch, the choroid plexus is within the cyst, whereas in Dandy Walker, it is outside the cyst. So feasible assessment can happen between 12 to 21 weeks, right? And distinctive position of the choroid plexus is what we look for. And early diagnosis is possible based on the position of the cyst. We can confidently say that this is Dandy Walker, this is Blake's pouch at around 12 to 13 weeks. There is a lot of research in the posterior fossa and also in the choroid plexus. Thank you.
Thanks, Murli. Fantastic presentation as always.
Welcome, sir.
You covered this in very granular detail. Amazing. Hats off to you.
Thank you, sir.
So now I would like to invite Dr. Prasanna Roy, and he'll be presenting on cerebral venous anatomy and anomalies. Prasanna, please share your screen.
Can we have the trade partner videos before that?
Yes. I think we can have trade partner video. Prasanna, you be ready. Let's continue the next gen webinar. So there are niche topics and then there are super niche topics. And the cerebral venous anomalies and anatomy is some, I would consider it as a super niche topics. Not many people look at the cerebral veins. Not many people are aware of the abnormalities that can affect the venous system of the brain. And when I thought of this topic, there was one person in mind, that is Dr. Prasanna Roy, who's a fetal medicine specialist working in Asansol, West Bengal. And his images are simply mind-blowing. Prasanna, over to you.
Thank you, sir. I'm audible, right?
Yes.
I'm audible, right, sir?
Yes.
Yeah. Good evening. Good evening, my respected seniors and my dear colleagues. I'll be presenting on fetal. Let me minimize this. Just a moment. Yes. So fetal brain veins, we'll look at the anatomy and we'll look at the anomalies. Now, this, with the exception of a few reports, this field of this intracerebral venous system has remained relatively scientifically unexplored. But with the publication of guidelines on fetal neurosonography, there has been growing interest in the comprehensive ultrasound examination of CNS. So, however, the clinical interest in the brain vascularity is scarce. It is less when compared to as in abdomen or heart, but there are specific reasons for this, and the reasons might be because of the complex anatomy of the venous system on one hand, and on the other hand, the inability to image the intracerebral veins. So the machine is a very key factor in this kind of imaging. So it's a complex blood vessel network. We all know it's a complex blood vessel network about. There are three parts to this, that is dural sinus system, the superficial venous system, and the deep venous system. And all these are interconnected with numerous anastomosis. So these are the basic three headings, that is dural sinus system, superficial venous system, and the deep venous system. Now, the ultrasound techniques, the planes used in the dedicated fetal neurosonography, as described in the ISWOC guidelines, can also be applied to assess the intracerebral venous system. In addition, we can also this mid-sagittal plane, when we do this neurosonogram according to the guidelines, the mid-sagittal plane is of the greatest value in visualizing the veins that course between the two hemispheres. And we use the anterior fontanelle or the metopic suture as the acoustic window. We can also use the axial and slightly oblique planes, which can be used to demonstrate the veins from the middle of the brain towards the torcular. But the mid-sagittal plane is of the greatest value. And TVS is an ideal complementary tool. Without doing proper TVS, we will not be able to achieve the proper images in these kind of abnormalities. So the venous blood flow, we all know the blood flow velocities are low. So we need a sensitive color and power Doppler to image these kind of veins. And there are typical presets, that is low PRF with velocities between 4 to 10 centimeters per second, low wall motion filter, and high persistence. And we need to take help of 3D with glass body mode for a spatial orientation. So the dural sinus system, one of the main features of the intracerebral venous system is the dural sinuses. So what are they? These sinuses are venous channels between dural layers. They lack valves and typical vessel wall layers. Because of this feature, it makes the intracerebral venous compartment less dependent on variations in venous pressure than other organs of the body. So what are the common sinuses which we need to look for in the fetal brain? That is superior sagittal and inferior sagittal sinus, the straight sinus, the transverse sinus, the sigmoid sinus, the cavernous, the petrosal, and the occipital sinus. So the common ones which we generally deal with are the superior, inferior, straight, and the transverse sinuses. The rest of the sinuses are difficult to image in the fetal life. So the superior sagittal sinus, the most important, is the largest sinus, and it's a course in the midline of the head along the superior margin of the falx. It runs from anterior to posterior, receiving blood bilaterally from several superior cerebral veins, and it drains in the occipital region at the junction of the falx with the tentorium into the confluence of sinuses, also known as the torcular hierophyly. Now the inferior is conversely a thin vein, not as thick as superior sagittal, which courses at the inferior border of the falx and superior to the splenium, or the vein which we see superior to the splenium is the inferior sagittal sinus, and it drains together with the vein of Galen to form the straight sinus. Now, here, when we image it with the fetal brain in the mid-sagittal section, you can see the pericallosal artery. We are very commonly used to see the corpus callosum in this fashion. So when we switch on HD flow or slow flow, you will see the pericallosal very nicely. And then when we go to slow flow or maybe lower the PRF settings, you will see this the superior sagittal sinus. It will course in the midline of the head, and it will run from anterior to posterior, and it will drain in the occipital region. This is the straight sinus, and this is the torcular, which is called as the confluence of all the sinuses. Here, the straight and the superior sagittal, they all meet in near the occipital bone, and that is called as the torcular hierophyly. So the straight sinus, which you saw, is a median single sinus. It is formed by the fusion of the vein of Galen and inferior sagittal sinus. Now it has an oblique course, and it drains together with the superior sagittal sinus at the confluence, which is called as the torcular. Now the straight sinus drains in most cases together with the superior sagittal in the confluence of sinuses, but there are some anatomic variations in this region with a separate course of the superior sagittal into the right transverse and the straight sinus into the left transverse. So there are some anatomic variations which can happen. Now the transverse sinuses, they run right and left in a groove along the inferior surface of the occipital bone, and they have a curved course into the base of the parietal bone. And from there, the transverse sinuses drain into the sigmoid sinuses, and then they go into the internal jugular veins and where they exit the cranium. So this is how all the sinuses run. The superior sagittal, the straight, they drain into the torcular. Then comes the transverse sinus and the sigmoid sinuses, which are difficult to image, and then they drain into the internal jugular veins where they exit the cranium. So this is the entire dural sinus system. So you can see here that the superior sagittal sinus is coursing along the superior border in the midline of the brain. And just above the splenium, you can see a thin vein, not as thick as superior sagittal, that is the inferior sagittal. This is the cavernous sinus. And this orange line, which I put, is for the straight sinus to mark the groove of the tentorium cerebelli, because the straight sinus will run along the groove of the tentorium cerebelli. And that is how we identify tentorium cerebelli, by switching on color and identifying straight sinus. We can also see the occipital sinus from the torcular. This is the region of the torcular where that is the confluence of all the sinuses. Now, here you can see that the inferior sagittal sinus, the internal cerebral vein, and the vein of Galen, they combine to form and they drain into the straight sinus. So the inferior sagittal, the internal cerebral vein form the vein of Galen, and then they together drain into the straight sinus, which then goes on to drain into the torcular. That is and the superior sagittal comes from above, and then the occipital, the sigmoid, and then they go out of the brain like this. You can also see the pericallosal artery and the basilar artery in this section. So by scanning through the metopic suture or the anterior fontanelle, the superior sagittal, as you saw, can be easily accessed. The superior sagittal and the confluence can be very well seen at the 11 to 13 week scan also. The inferior sagittal, on the other hand, is very small and it's not regularly seen prenatally, but can be visualized mainly in the third trimester. But it can be easily seen if you switch on slow flow in the second trimester also. So the bilateral transverse sinuses have a curved course and can only be partly demonstrated in the fetus. And they can be ideally seen not in the mid-sagittal section, but in the transcerebral plane, directly along the inner border of the occipital bone, and where they will be showing a direction of color Doppler away from the midline. I will show you the images. In a more caudal plane, the course of the sigmoid sinuses can then be seen, showing the opposite color flow direction. I will show you the images. And a coronal view of the neck and occipital region can illustrate the tortuous. If you see the base of the skull, only then you'll be able to see both the transverse and the sigmoid sinuses. So as I told you, the sigmoid, the superior sagittal sinus and the confluence of sinuses can be very nicely seen in the first trimester also. And it has value and visualizing this vascular pattern has a value in many types of abnormalities, which we'll come to later. So this is slow flow image and this is a rendered image on the right side. So if we try to see the sigmoid sinus and the transverse sinus, their visualization is done in an axial and a posterior coronal plane. In the axial plane, at the level of the cerebellum, as you see where we measure the TCD, the two veins are seen arising from the torcular. The torcular is not seen in this axial section, but they have a course in a lateral direction. Now, if we rotate the transducer into a coronal plane, it changes the course of the transverse sinuses and part of the sigmoid sinuses is seen with a course downwards towards the neck region. So these are the transverse sinuses, and when we rotate the transducer into a coronal plane, we get to see the sigmoid sinuses. So using 3D and glass body mode with slow flow will give you a spatial arrangement, and especially when there are abnormalities. So practicing 3D with slow flow or HD flow or color Doppler in normal cases is very necessary in every case, so that when some abnormality is there, we can easily make out that there is some aberration in the anatomy. So we come to the superficial venous system. We are done with the dural sinuses. Now the superficial venous system, the brain parenchyma is drained mainly by cortical and medullary veins, which empty either into the veins on the cortical surface or into the deep venous system. Now these cortical veins, they drain into superior cerebral veins with a course along the cortical sulci. So a prominent vein of the superficial venous system is the Sylvian vein, which runs along the Sylvian fissure. Now, this vein is also connected to the superior sagittal sinus via the superior anastomotic vein of Trolard, and with the transverse sinus via the inferior anastomotic vein of Lab. So, the undersurface of the cerebral hemispheres is drained by the inferior and middle cerebral veins as well as the basal veins of Rosenthal. So, these anastomotic veins of Lab, Trolard, and Sylvian, these are all superficial venous system. So this is the schematic of the superficial venous system. You can make out that there are basically three anastomotic systems, that is the Trolard, the Lab, and the Sylvian systems. But these are very difficult to image because they lie directly under the skull. And here you can see in purple color the sinuses are labeled. This is the confluence, that is the torcular. This is the transverse occipital sinus, and this is the superior petrosal sinus, sigmoid sinus, going outside the brain through the internal jugular vein. So this is the superficial venous system. So, when we do the ultrasound of the visualization of the superficial system is challenging, as I have told you, because most veins have a curved course and they are hidden in the shadow of the skull. We generally do not image this superficial venous system. Now, veins at the base of the skull will have a course side by side with the arterial circle of Willis. And that is the problem, because lowering the velocity scale near the circle of Willis will lead to signal overlap and a difficulty in identifying the veins. That is why imaging these veins are so difficult. Now, the bilateral basal veins of Rosenthal, they have a course around the cerebral peduncles and can be occasionally well visualized in their course and lateral drainage into the vein of Galen, because all these veins, they drain into the vein of Galen, these bilateral veins of Rosenthal. Now we come to the deep venous. So you understand that the superior venous system is difficult to image. Now we come to the deep venous system. Now these deep medullary veins are very small intercortical veins with a radial course towards the lateral ventricles. Now they converge and drain into the several subependymal veins, which also receive blood from the basal ganglia, CC, and the fornices. Now, there are many deep veins like the choroidal, caudate, thalamostriate. They come from all these deep nuclei, and they merge together. All these deep veins, they merge together and enter the third ventricle to form the left and right internal cerebral veins. The most important structure in the deep venous system is the internal cerebral veins, which is a bilateral structure. They are paired veins. These internal cerebral veins are paired veins with an almost parallel course from anterior to posterior, arising at the level of the foramen of Monro with a course on the roof of the third ventricle. Now, what happens to these internal cerebral veins? They fuse at the region of the splenium of corpus callosum to form, together with the veins of Rosenthal, the great cerebral vein of Galen. Now, all these paired internal cerebral veins and these paired veins of Rosenthal, they meet at the splenium of the corpus callosum to form the vein of Galen. Now, this is the schematic where you can make out that this deep venous system, you can see all these are if we see from a medial view, this is a medial view schematic system. Most of these veins will be found in the midline. You can see these veins are in the midline, and this change occurs and this flow occurs from the anterior to posterior. Now, the several deep small veins from the left and right, they will merge to form together to form these bilateral internal cerebral veins. All these smaller veins will form the internal cerebral vein. Now, this internal cerebral vein, it's a bilateral structure, as you can see. It will be joined by the Rosenthal veins, and then they will form the vein of Galen, which will be joined by the inferior sagittal sinus to form the straight sinus. That straight sinus will go down to the torcular. So this is the drainage of the deep system, how it occurs. So you can see here that when we switch on slow flow in the mid-sagittal section, because deep veins are easy to see because it's in the mid-sagittal section, the skull bones are not coming in between. So you can see very small veins which are draining into the internal cerebral vein. We can only see one part of the internal cerebral vein, unilateral, and this internal cerebral vein with this inferior sagittal sinus then drain into the vein of Galen, which goes into the straight sinus and into the torcular. So which we see this deep venous system when we switch on the slow flow in the mid-sagittal section. Now, ultrasound visualization, because there are three important veins we saw, that is the bilateral internal cerebral veins, the vein of Galen, and the straight sinus. They lie between the hemispheres and they form an angulated line. I will show you later. So they are the easiest veins to be demonstrated prenatally, with the best visualization being the sagittal plane, which I have shown you. So, but a potential mistake in the sagittal plane, who are regularly putting on slow flow in the mid sagittal plane will know, is to misdiagnose the internal cerebral vein as the posterior branch of the pericallosal artery, especially in early gestation. We should avoid this mistake. Now, this course of these three veins, they will change slightly during gestation from a straight to a more angulated course. In the second half of gestation, the internal cerebral veins are found under the splenium of the corpus callosum. So, as I told you, in the first trimester, you can see the direction is more or less straight. That is the straight sinus, along with the internal cerebral vein of Galen, is having a straight course. But at 23 weeks, you can see there is an angulation with the vein of Galen with the straight sinus. And in third trimester, this angulation further increases. So this is a normal variant. And this is called as the kinking of the vein of Galen with progressive gestation. Now, these three veins can be demonstrated in a sagittal plane, but also separately in axial planes. We can see these veins in axial planes right at the first trimester if we use high frequency linear or transvaginal transducers. You can see here that in first trimester, the internal cerebral veins, these are paired internal cerebral veins, and they are seen in an anterior-posterior axial plane. They are joining to form the vein of Galen, and they are some lateral tributaries are seen draining into these internal cerebral veins. You can visualize them right at the first trimester. So this image we are seeing from superiorly after removing the CC. Suppose we remove the corpus callosum and we are seeing from top to bottom. The main veins are these two. That is the bilateral internal cerebral veins parallel course along the third ventricle. They have a parallel course along the third ventricle and the choroid plexus of the third ventricle. So several deep veins like these, all these deep veins, they drain from the cortex, the ventricles, and the deep nuclei, and they merge together to form the internal cerebral vein on both the sides. Now, these internal cerebral veins, they merge at the level of the splenium. As I've told you previously, at the level of the splenium, this is the splenium, and together with the basal veins of Rosenthal, they form the vein of Galen. So if you remember this image, the schematic, and see this image, this is at 28 weeks of gestation, and it's a coronal image on slow flow. You can see both the bilateral paired internal cerebral veins, and these internal cerebral veins are being supplied by all these small tributaries on both the sides. So you can visualize these internal cerebral veins with slow flow, but at an advanced gestation. Now we come to some abnormal. We have done with the anatomy, that is the dural sinus, the superficial system, and the deep venous system. Now we come to some common abnormalities of the venous system. The first, very commonly, that is the vein of Galen aneurysmal malformation, or also called as VGAM. So VGAM is a rare congenital malformation. It's defined as an AV fistula between primitive choroidal arteries and an overlying single venous sac. So it's a kind of an arteriovenous fistula between the primitive arteries and an overlying single venous sac. But there is evidence that this sac is a persistence of the median prosencephalic vein of Markowski and not the vein of Galen per se. Now, cases of VGAM have happened without the presence of the Galen vein, and these type of cases have also been reported. But nevertheless, it is agreed to keep the description unchanged as vein of Galen aneurysmal malformation. Now, it develops probably early in embryogenesis. We all know between 7 to 12 weeks of gestation, but the prenatal detection occurs typically in the third trimester. Now, there are extracerebral signs and intracerebral signs, and this typical scenario is different, but these extracerebral signs sometimes are the first signs by which we can suspect that there is a VGAM malformation. What are the extracerebral signs? That is dilated jugulars, dilated LBCV, cardiomegaly with tricuspid insufficiency, or pericardial effusion, ascites, hydrops, and polyhydramnios in the third trimester. When we get polyhydramnios in the third trimester, we need to look at the brain very nicely. And what are the direct signs? That is a cystic mass in the midline of the brain. And when we switch on color, there will be turbulent flow. There can be the drainage to the venous sac can be through a dilated straight sinus or a persistent falcine sinus, and there can be dilated lateral ventricles and hyperechoic borders of the lateral ventricles. So the VGAM, basically what is the clinical impact of an annual VGAM is it has a very low prevalence, only in 1:25,000 deliveries, but it is the most frequent cerebral arteriovenous malformation which can be detected prenatally. And the overall mortality rate is currently 10 to 15%. And prenatally diagnosed VGAM carries a poorer prognosis, especially when associated with cardiac failure or cerebral damage. Now, Chow et al. Reported on a survival rate of 78% with normally or mildly disabled functional outcome in 50% in a review of 41 cases. In this study, it was reported that predictors of adverse clinical outcome were younger age at first diagnosis, congestive cardiac failure, and seizures. Now, advances in imaging and interventional neuroradiology are promising to avoid complications and decrease the morbidity and mortality rates of affected neonates. So when we see this type of image, you can see the typical scenario for a prenatal diagnosis is usually the detection in the axial plane of a cystic or tubular mass in the midline of the brain. Here you can see there is a cystic and a tubular mass in the midline of the brain, and a draining vein. When we switch on color, you can see a draining vein might be seen connecting to the occipital region, and the use of color reveals a high turbulent blood flow in the cystic structure, which differentiates it from other findings like arachnoid or something else, arachnoid cyst or some other structures. And the high perfusion can be associated with secondary cerebral and intracerebral changes. Now, these are the, and in the same case, you can see these are the extracerebral signs which I have showed you. There is cardiomegaly and there are dilated bilateral internal jugular veins. Now, when we switch on power Doppler, you can make out that how that dilated sac is draining into into the torcular through the straight sinus, because this dilated this vein of Galen malformation, they can drain by two methods, which I have shown you previously in that slide, that it can drain via the dilated straight sinus, or it can drain via a falcine sinus, or both can be present. But in my case, you can very well nicely see here, this is a rendered 3D image where the sac is draining by a dilated straight sinus. In the transvaginal images, you can again make out that the aneurysm part and the cystic structure. You can also make out on 2D that there is turbulent blood flow. But when we switch on color, there we can easily make out the aneurysm, and it is draining via the dilated straight sinus and into the torcular. And on 3D reconstruction, you can make out the spatial arrangement and all the venous channels, that which particular area is actually dilated, whether it is through the straight sinus or whether it is through the falcine sinus, and whether other sinuses are dilated or not. So 3D reconstruction with a spatial arrangement always gives us a typical and a particular diagnosis in this kind of venous malformations. And if you walk through and do perspective rendering in these type of cases, you can make out that sac. You can also make out the walls of the aneurysmal sac if you walk through and come out and do perspective rendering. So we come to the next one, that is dural sinus malformation. Now, these dural sinus malformations are rare. They are congenital intracranial vascular malformations, and they are characterized by dilatation of one or more dural sinuses, and secondary to AV shunting that develops early in prenatal life. Now, these DSMs have two anatomical types according to the Las-Januas classification. The number one is the midline and torcular DSM, showing involvement of posterior dural sinuses, resulting in a giant venous pouch with slow flow mural AV shunting, and the number 2 is the lateral dural sinus malformations involving the sigmoid sinus and the jugular bulb. So antenatal ultrasound with color Doppler is the primary imaging modality for the diagnosis and prognosis of dural sinus malformations, and MRI is a second step examination. Now the vascular dilatation with AV shunt usually shows low velocity blood flow, which commonly predisposes to partial to complete thrombus formation, which may appear heterogeneous. Now, this high velocity blood flow with heart failure, unlike VGAMs, is very uncommon. In this dural sinus malformations, heart failure is very uncommon. Now, this case we have taken from Dr. Mohit Shah, our president, and this case was published in the ISWA journal, where it was you can see a large cystic mass in the posterior part of the brain, and it was an antenatal dural sinus malformation of torcular herophily and straight sinus. So the malformation is in the straight sinus and the torcular herophily. You can easily make out the location is in the posterior part of the brain near the occipital bone. And here are the images. This is the mid-sagittal section where you can see a big mass. It is still not thrombotic, so you can make out blood flow in that. When we switch on HD flow, you can easily make out that there is a turbulent blood flow. And this case had cardiac failure, and it was different from other DSMs in having cardiac failure in the fetus. So this is the rendered 3D glass body image where you can see there is a saccular dilatation in the posterior part of the brain. And these are the MRI images. MRI is very important to diagnose other cerebral parenchymal damages or cortical malfunctioning. So you can also easily make out that there is a big cystic mass in the posterior part of the brain. And next we come to the dural sinus thrombosis. Now, thrombosis of the dural sinuses in the fetus, they occur as a local event, most commonly in the torcular region. We all know the torcular region is the commonest region where it happens, but can also rarely occur in other superficial veins as well. It occurs between the second and third trimester in otherwise uncomplicated pregnancies. And in most fetal cases, the etiology is idiopathic or can be due to a local vascular structural anomaly causing local flow disturbance. It's a local event. But in infants and adults, it can happen because of trauma, polycythemia, infection, or hypercoagulable state as etiological factors. Now, what are the ultrasound signs in dural sinus thrombosis? That is an echogenic mass at the level of the torcular herophily. We can see an echogenic mass at the torcular, a triangular fluid collection in the occipital region. We can also see dilatation of the distal superior sagittal sinus, absence of blood flow in color Doppler, just the opposite of VGAM or dural sinus malformation. You will not get any blood flow in color Doppler, and optional mild ventriculomegaly or compression of the occipital cortex. Now, in contrast to earlier small case reports, what has happened is the two recent case series and reviews of literature, they emphasize the favorable outcome in 60 to 70% of cases, especially when the clot decreases in size or even disappears completely with recanalization of the sinus prenatally. So recanalization of the sinus can happen prenatally itself. However, this lesion can lead to local ischemic cortical damage due to parenchymal hypoperfusion and compression, which can lead to a poor neurodevelopmental outcome or fetal demise. Now, follow-up is very important because it will provide valuable information on the dynamic changes at the level of the lesion, that whether the clot is disappearing or not, with the expected regression or on the possible appearance of cortical changes. We need to do an MRI also. Now, this case, basically, I have taken from Dr. Min Son Pham and Can Pham from the Da Nang Hospital in Vietnam, where they have brilliantly shown a case of dural sinus thrombosis. You can easily make out in the posterior part of the brain, there is a big clot. This is a coronal image, and you can see it's a triangular collection of fluid, which was written in the signs of the dural sinus thrombosis. The fluid collection is triangular, and an echogenic mass will be seen at the level of the torcular. And when you do mid-sagittal section, you can easily make out that there is a big mass, there is blood in the posterior compartment, and an echogenic blood clot is also there. And when you move further, you can see here that you can make out blood flowing into that posterior compartment of where that insult has happened. So generally, this is a local event and no other brain changes are generally seen in these type of cases. This is the MRI where you can see that it's a triangular fluid collection and you can very well make out the clot in the posterior part. This case also from Dr. Nguyen Lan, is the head of the Department of Prenatal Diagnosis in Ho Chi Minh City, and brilliant imaging again where we can see triangular fluid collection in the posterior part, and we can see an echogenic blood clot in the at the level of the torcular. And when we switch on color, you can make out that there is no color uptake in this clot, which will differentiate it from other hypervascular condition. We know that it's a thrombosis and not a dural sinus malformation. So this next case, we come to the dural AV fistula. Now these dural AV fistulas, they are abnormal connections between the dural sinus and the meningeal arteries. So it's a fistula. So the vein is the sinus and the artery is the meningeal arteries. So they are congenital lesions and they most commonly affect the transverse, sigmoid and the cavernous sinuses. We have learned about these sinuses in the beginning. So they most commonly affect these sinuses. Now it constitutes about 5 to 10% of pediatric intracranial AV shunts and may lead to fatal high output cardiac failure. And it has a lower rate of angiographic shunt obliteration and a poorer clinical outcome when compared to VGAM. So these dural AV fistulas have a poorer clinical outcome when compared to vein of Galen malformation. In this case we diagnosed at 31 weeks. Actually, the case presented to us with polyhydramnios. So as I told you, whenever we see unexplained polyhydramnios, we start to look at the fetus in great detail. And when we found nothing except this finding that unequal flow in both the middle cerebral arteries were there when we switched on color in the brain, you can easily make out that the right side is appearing normal, but the left side is appearing dilated. So unequal flow in both the middle cerebral arteries and unexplained polyhydramnios, and triggered questions in our mind that there might be some problem with the venous sinuses in the brain. Here you can see that the transverse sinus, as I have told you, that these dural AV fistulas are very commonly seen in transverse sinuses. This dilated transverse sinus is connected to the left middle cerebral artery. So it's a AV fistula where this left middle cerebral artery is connecting to the dilated transverse sinus. Here on this is power Doppler and this is slow flow, where you can easily make out the saccular dilatation of the transverse sinus. So we did a 3D glass body and you can see so nicely the dilatation is seen, and the dural AV fistula was in the left basitemporal region, and the feeder vessel is the left MCA, that is the middle cerebral artery, which was dilated, and the draining vein is into the left transverse sinus. This is the left transverse sinus. So the feeder is the MCA and the draining vein is the left transverse sinus. So this is the dural AV fistula, which we diagnosed at 31 weeks. And this is the post-birth, the baby was delivered by cesarean section at term. No complications happened. And this is the post-birth MRI, contrast MRI, where you can easily make out the dilated part of the transverse sinus after giving contrast. And the baby is doing perfectly fine now. It's 2 years of age and no neuromotor deficits are there in the baby right now. So this case I've taken from Dr. Karthik Senthilvel. He published it in the ESWAG journal, where again you see a dural AV fistula. My case was at with the transverse sinus, but he found this at 19 weeks of gestation, and the arterialization was with the sagittal sinus. So you can make out that there is a lateral feeder, and the dilatation, the venous part is the superior sagittal sinus. This is the dural AV fistula involving the superior sagittal sinus, and this case was accepted as case of the month by the ESWAG journal. This is a case by Dr. Karthik Senthilvel. So other scenarios where we can use the intracerebral veins are the Kyrie 2 malformations and Dandy Walker malformations. Now, the position of the tentorium has been used in the past, as shown by Murli sir in the previous lecture, that it's used in the past to differentiate between Kyrie 2 from the Dandy Walker. In Kyrie 2, we all know the tentorium will be low because the brain is pulled down, and in Dandy Walker, it will be high. So the course of the straight sinus follows the tentorium, which I've showed you in the anatomy images, and thus could be used as indirect visualization of the tentorium. Sometimes visualizing directly on grayscale the tentorium is difficult. So if we switch on color, or power Doppler, visualizing the straight sinus will give us an idea of where the tentorium is. So this visualizing the straight sinus and noting that it is high in Dandy-Walker malformation and low in open neural tube defect or Kyrie. So this is a case of open neural tube defect. You can very well make out that the brain is pulled down, and when we switched on slow flow in the mid sagittal section, the very low position of the torcular should be here somewhere, and it has been pulled down because the brain is pulled down because of the CSF leak in the open neural tube defect. So you can make use of switching on slow flow and identifying the straight sinus very easily, because the straight sinus follows the tentorium cerebelli. So we can switch on color and make use of that anatomical importance. Now we come to the falcine sinus. During embryonic development, variants of the forerunner of the straight sinus and the Galen vein, they exist, and include an additional sinus between the dural leaves of the fox cerebri. This sinus can persist, and when it persists, it is called as the falcine sinus. Now, this falcine sinus, they connect either the vein of Galen or the inferior sagittal sinus directly to the superior sagittal sinus. I will show you. And it can be found instead of the straight sinus or in addition to it. So straight sinus can be there. In addition to that, falcine sinus can be there, or straight can be absent and falcine can be present. So falcine sinus are present basically in three scenarios. It can be a drainage site within the vein of Galen aneurysmal malformation, or it can be a draining vein of a vertex cephalocele on an atretic parietal cephalocele, or simply as an accidental anatomic variant with unknown clinical impact. So these three scenarios we should always remember. It can simply be a normal variant, or it can be present with vein of Galen or atretic cephalocele. Here it's a with normal variant. I have labeled the falcine sinus for you. You can see that it is draining this internal cerebral vein and directly to the superior sagittal sinus. It is not going via the straight sinus, but in this case, no other abnormality was there. So we diagnosed this as a normal anatomic variant. This is how a falcine sinus looks when it drains directly into the superior sagittal sinus and not via the straight sinus. But in this case, this case is from Dr. Alpesh Pancholi. This case has been published in our Journal of Fetal Medicine, where you can make out that there is an atretic parietal cephalocele. On grayscale, you can see there is an atretic parietal cephalocele. And on switching on HD flow, you will be able to see the falcine sinus. So I have told you three scenarios. One is a normal anatomic variant. One is with vein of Galen. I don't have that case with vein of Galen, but this is a case which I have taken from Dr. Alpesh Pancholi, and he has shown beautifully how this falcine sinus is draining into the superior sagittal sinus in association with an atretic cephalocele. So this is a 3D glass body stick where you can see that the falcine sinus is draining directly into the superior sagittal sinus. Now, lastly, we come to a normal part of the brain, that is the visualization of the intracortical medullary veins. Now, until recently, only large cerebral veins like the sinuses, and the deep veins were accessible to visualization on color or pulse Doppler. But with the advent of sensitive high definition color Doppler, Dr. Ritsuko Poo was the first to use transvaginal ultrasound to visualize the fine medullary veins in the fetus between 18 to 30 weeks, and where they run from the pile surface toward the subependymal area. I will show you. In the early second trimester, the medullary veins, they appear as numerous shower-like vessels, which after 20 weeks drain mainly centripetal, that is from inside to outside, into the corresponding subependymal veins or the longitudinal caudate vein of Schlesinger. So this has a shower-like vessel appearance is there of the intracortical medullary veins, where if you switch on, you have to zoom the image to that level by this is a transvaginal image in a 27 weeks fetus, where by switching on slow flow, you can make out this shower like pattern, which is diagnostic of the intracortical medullary veins. And if you do a 3D rendering of this medullary veins. This is the mid-sagittal section, but if you look at it from top to bottom, that is the coronal plane. This shower-like pattern you can easily make out and render on 3D glass body mode, and which is from peripheral to central. This flow is from peripheral to central for the medullary cortical veins. So this is all and thank you SFM for the opportunity to present such a complex topic in front of you all. Thank you so much. Thank you.
Thank you, Dr. Prasanna. Amazing, mind-blowing, excellent. I think I'm going to run out of superlatives for your presentation. And I hope everybody has enjoyed your hard work and artistry when you create all these images. I'm looking forward to see many of your presentations. Thank you, dear Prasanna. Thank you very much.
Thanks.
Now, Rana sir, I would like to invite you to give your comments and handle the few questions that they are there in the chat box.
Yes, of course. The comments, first of all, it's been a visual treat, but indeed a greatly satisfying academic treat as well, because it's not just that everybody had spectacular images and they were absolutely full of information and completely way ahead of their time, but especially because they have a direct bearing on clinical diagnosis and clinical utility. And in so many of these situations, we can just happily carry on with the pregnancy, and the others, it would be a disaster to actually carry on. So this was absolutely amazing, and I'm so glad we put our foot forward on taking forward this Gen Next, because I think it's going to be a treat. At any given time, we had over 350 people, and I can understand why, because the content was really superb. Coming on to the questions, and of course, I must congratulate all three of our speakers, and I must congratulate Alok for putting this together so beautifully. Now, the questions are very few, but we'll start with that. And the first one was a general question from Ravi Reddy, whether is the open fourth ventricle a pathology in all weeks? And we know, of course, it is not. But moving on from there to more direct questions, we have the question that actually takes us to the point of, can we get the video recording? And of course, you know, all our webinars go on to video recordings, which then appear on the SFM YouTube channel and are available there for the whole world to see. And we keep them there. And the content, of course, is always cleared and supervised. But as long as they clear that test, all our recordings are always there. Now, the question that Neera Jindal has asked from Seema Yadagiri is how to differentiate between the CBL and vermis in the SAG view.
She means cerebellum and vermis.
She means the cerebellum and the vermis in a sagittal view.
Yes, sir. So when we take mid-sagittal sections, we get to see vermis. In cases of joint, what happens is whenever we going through and through from side to side, we see a echogenic structure coming, and just beneath it is a less hypoechoic structure that is the cerebellar hemisphere of the other side. So that is what I understand.
Excellent.
Correct me if I'm wrong.
And there's a related question on the relationship between the aqueduct of Sylvius and the midbrain, the anatomical relationship.
So aqueduct of Sylvius, it traverses in between the tectum and the tegmentum. It just traverses in between. It's just
Correct.
seen as a whole in the axial section. Sagittal section, it is seen as like a slit. Aqueduct of Sylvius is seen between the tectum and the tegmentum. Tectum posteriorly and tegmentum anteriorly.
Yes, and which brings us to the next series of questions. Actually, there's been so many compliments and such few questions. I think the lucidity was amazing. Everybody was just fascinated. And of course, folks like me were deeply, deeply satisfied, as I'm sure most of the stalwarts were, that we've stood our test and brought up a generation that we can be truly, truly proud of. To all of you, a big thank you for that. There's a very interesting basic question from Professor Avinash Gomkale, and that is, what is the difference between a sinus and veins? Prasanna, this one is for you.
Sinus will not help valves, sir.
Right.
The sinuses basically they are, dural, they are
They
between the
lack,
dural
they
leaves.
lack valves and all the layers of the
Yes.
veins, which all the wall muscular layers of the veins, they lack it.
That is right. And embryologically, therefore, they're completely different organs, and therefore they function differently. And one would fill up passively, extensively, and therefore the dural veins would therefore show much more disease than the regular veins. Then there was this great appreciation for all those 3D images, mind blowing, and what else. And everyone said hats off to all of us. And we're just so pleased that all of this came on. And now, Dr. Manohar Sivasamy wanted any report from India on ultrasound guided vein of gallon aneurysmal coil occlusion prenatally from India, that is.
Can I answer that?
Yeah.
Yeah, I had the opportunity to assist one in Boston Children's Hospital,
Yeah.
but that baby didn't do well.
Yeah.
Yeah.
That was in 2018.
Yes.
So
of course.
usually when I spoke to the neurosurgeon, they say 3 months to 4 months postnatally is when they try. And prenatally doesn't have good prognosis as of now. I spoke to my neurosurgeons here. So they are not too aggressive on coiling vein of Galen prenatally. Its
Mhm.
prognosis is not that great.
But
So
has
they
been
usually
done any, do we have
there are
medical?
some cases, sir. I mean, some people have tried, but it's
Yeah.
not been good, great results.
We thought we saw that in Isuak's soul as well,
Yeah.
but none of
Ah,
the
yes.
outcomes have really been very
Yeah.
encouraging.
Uh, I guess we have to strike at the root of the abnormal physiology rather than at the root of abnormal anatomy. And that is one of the principles that we must learn to follow as we go along in fetal medicine. Then there is this question of if at 34 weeks, we still see a connection between the fourth ventricle and the cisterna magna in the axial, but the sagittal looks good. Is this a normal variation? Anything of concern?
At 34 weeks, if you're seeing it, maybe your angulation is not proper. I mean, you're going too it's angulated. If you're seeing them now properly, everything looks normal. The worm is in axial. The look of the worm is looks fine. You're angulated too much. That is where you're going to see that opening.
Excellent. The next question is from Saurav Sharma. Do you use brain colored Doppler routinely for isolated polyamnios? And was AV fistula suspected on 2D also?
So when we see isolated polyhydramnios, the first structure we go and see is the diaphragm. So suppose we have missed it and the anomalies because this has happened twice with us. But after this case, we also switch on slow flow in the and HD flow in the fetal brain. This case, how we diagnosed, because the growth was normal, but the MCA, the left one was close to the probe at first. So when we imaged it, there was a lot of diastolic flow in the middle cerebral artery, and the growth was normal. So we were surprised, but that why such hypoxia is there in the brain. And then suddenly, when we saw the other contralateral MCA, we saw that it is absolutely normal. And then when we look closely enough, then on grayscale itself we saw that there was turbulent blood flow under the skull base, and when we and switching on color will or power Doppler will give you a diagnosis instantly. And we looked at the left side of the heart also to see whether there is any heart cardiac abnormality because of which there is some AV abnormality, but there was none. The heart was normal, and then the MRI post birth proved that it was a dural AV fistula. So now when we see isolated polyhydramnios, we generally switch on power Doppler or slow flow in the fetal brain and look at the diaphragm, both.
Excellent. So that completes the questions that we had, and I want to have my final comment here. And that is, you have seen world-class, expensive technology used for everyday fetal problems, but each one of our speakers comes not from a metro town, not from a primary or secondary level town, but really towns that are located in the periphery of the world, not just in the periphery of India. And here we've taken world-class technology to the point of first care to our patients at the cost of the pockets of our family and our daily existence, and sacrificed luxury for the sake of our patients. And I really want to congratulate our speakers today for this, that you have made world-class technology available to the poorest person in the country and the one who's furthest away from technology, and yet made it available to them. And more importantly, that each one of us at SFM is making similar sacrifices every day. I think we can congratulate ourselves for this. We are really
Absolutely.
the only place in the world that has achieved giving high technology at the point of first care. Congratulations,
Absolutely.
everyone, and thank you for
Yes,
this.
thank
And
you.
over
Thank
to
you.
Dr. Mohit Shah for his closing remarks here.
So I find, short of summarizing this in one word, brilliant is such an understatement. All three of you, I'm so proud of you. Seema, the way you have understood the concepts of the fourth ventricle and the embryological aberrations to put it into that context, and looking at your images, it is such an inspirational theme that you give to the youngsters, that every time you see one thing which is abnormal, you have to go in depth, take all the sections so that you can conceptualize the anatomy in 3D and then come to a conclusive diagnosis. Just marvelous. Murli, we have been hearing about choroid bars all throughout. You've shown the choroid bar too well, but more importantly, your 3D images have really helped understand embryological aberrations wonderfully. That rendering at such an early gestation talks a class about your 3D knowledge as well as putting into practice. Very well done, Murli. And Prasanna, a super niche topic, wonderfully presented. We don't ever make an attempt, specially to look at the cerebral veins, but the way you have shown all the cases is mind blowing. I remember Ritsukapu showing the medullary veins, and I found it very difficult to replicate the kind of images of the medullary veins that she's created. It's a tough job, but I think you've done a marvelous job of creating those medullary veins in your presentation. So I completely agree with Kurana, sir. This is absolutely mind blowing, inspirational. I am, pardon me, I am not on video because I am more than half a world away. But I got up at 4:30 here in the morning just for this inaugural session because I knew this was going to be mind blowing, and you made that effort worth it. It was wonderful. We are so proud of you, and we look forward to much more participation going forward. Looking at the response from the audience is really heartwarming. Thank you so much, each one of you. Thank you, Alok, for putting it all together. It was a wonderful concept, and I see it going a long way. Thank you all.
Thank you, everyone.
So,
Good night.
Good night, sir.
Good night.
night, everyone.
Good night,
Bye.
sir.
Good night. Good night.